Well, hello, Dr. Goyal. How are you?
I'm well. Nice to talk with you today, Richard.
Nice to talk to you as well. Welcome to Rare Awareness Radio. I'm so pleased that you're able to take some time to speak with us today. Thank you.
I'm happy to be here. Myositis awareness is near and dear to my heart and a passion of mine. So great that we're talking.
Okay, perfect. Thank you. Well, I want to introduce you a little bit, but I also would love to give you an opportunity to introduce yourself. But for folks listening, we are speaking with Dr. Namita Goyal from University of California, Irvine, or UCI Health, where she's a professor of neurology and director of neuromuscular medicine at UCI Health. Do I have all of that correct?
That's all correct.
That's wonderful. And
It's that I enjoy.
yes, and you and I share a little bit of a geographic bond in the sense that you did, spend some of your time with your training here in the Boston area at Harvard.
Yes, that's right. I did my fellowship there, and then I actually spent 7 years on faculty at Mass General Hospital and really enjoyed it. And it's actually there where I became passionate in myositis.
Hmm,
And I've been here at UC Irvine now for 13 years, so
wow.
in the field for 20 years, and have enjoyed every day.
You've got a lot of, really, I think, specific and interesting research interests around neuromuscular disorders, whether it's ALS or myositis, which we're really gonna talk a lot about today, but there's other interests you have around muscular dystrophy, myopathies. Would you talk a little bit about, sort of in total, the things that interest you, Namita?
Yeah, no, I love, talking with patients and examining patients and listening to their diagnostic odyssey. And I think that's where my research interests have stemmed is hearing about the diagnostic and management odyssey for many patients and thinking this day and age, we should be doing more, we should be doing better.
Yeah,
And a lot of these patients that have no major therapy that's groundbreaking for them is not acceptable to me. And
right.
so that's where I have explored different therapies, working on clinical trials for many of these conditions.
Mhm.
Uh, Muscle and ALS both share a similar passion of mine because of many of these unmet needs.
And you said a second ago when I was talking about your time here in Massachusetts and then your transition into UCI Health, you mentioned it was myositis, right? That kind of brought you there. Can you talk a little bit about that inspiration to pursue sort of this focus? And then I also think it might be important, Dr. Goyal, because we have people that will be listening to this that are being first introduced to myositis. So I think it might be helpful for you to kinda help us understand a little bit more about the condition.
Yeah, speaking to why I became specifically passionate about myositis, I actually still remember the specific patient who was having such a delay in her diagnostic journey
Mm,
that treatment was delayed for her.
mhm.
And because we couldn't get some of the diagnostic tests as an outpatient in time, including a muscle biopsy, the patient was ultimately hospitalized with very severe progressive weakness.
Oh, wow.
And I actually met with the surgeon at that time and I said, can you train me as
Mhm.
a neurologist in muscle biopsies to help the diagnostic odyssey
Hmm.
in patients? And this is now nearly 20 years ago.
Wow.
And at Mass General, I'm proud to say I, successfully did the muscle biopsy in many of these patients, but I think I really improved that diagnostic delay that patients were having.
Mm,
And with that, I met many myositis patients and thought, we really need to get better at diagnosis, get quicker, increase awareness, and then get on treatment
mm,
quicker because many of the myositis
mm,
are treated.
mhm.
And when you were asking about, the type of myositis,
Sure.
um, a lot of people initially, back in the 1800s, it was polymyositis that was discovered as the first myositis.
Wow.
As we got smarter with autoantibodies and clinical features, that's where subtypes started breaking off.
Hmm.
And so a lot of people still think, oh, it's polymyositis.
Mhm.
As we've gotten smarter about the subtypes and recognized different clinical features, different treatment responses in some, we now really characterize patients as dermatomyositis,
Sure.
with the skin changes and the proximal muscle weakness, antisynthetase syndrome, which oftentimes has also additional lung involvement
Mm.
in addition to skin and muscle, necrotizing myopathy, where patients typically have more severe muscle involvement, but not some of the other multisystemic features.
Mm.
Mixed connective tissue overlap, where oftentimes we use some of our rheumatology colleagues because there is sort of a mixed picture of connective tissue disorders as well as muscle weakness.
Hmm.
And then a completely separate entity called inclusion body myositis. And the reason I say completely separate is all these other ones, dermatomyositis, antisynthetase necrotizing myopathies, are categorized as autoimmune
Mm.
as they are treatment responsive.
Mm.
Inclusion body myositis, we consider a separate entity because we still haven't found a great treatment for these patients, and they don't respond to the classic autoimmune
Mm.
therapy.
Doctor, we've spoken to a few folks now related to myositis. And the one thing that has struck me, I'm a public health professional, but I'm not a clinician. I spoke with Dr. Yasmin Ventura, who you might know at the University of Chicago, who is an expert in interstitial lung disease and really looking at myositis from, as you mentioned, some of how the lung and the skin are often involved, the multisystemic view. You're a neurologist, and you're looking at it from a neurological point of view. There's the rheumatology aspect of this as well. All of this kind of leads me to kind of thinking more and more about how multidisciplinary the treatment approach is to myositis.
Absolutely. I think what we recognize is in these different subtypes, and I think that's why actually identifying which subtype a patient has
Mm.
is super important. We use that help with autoantibodies and muscle biopsies to
Mhm.
try to narrow it down.
Mhm.
But, depending on the subtype, there's a higher risk for multisystemic involvement,
Okay.
especially dermato
Mhm.
antisynthetase. We're looking at lung, skin, GI, in rare conditions, cardiac.
Mm.
We do need those specialists for the multisystemic involvement because different systems do respond to treatments differently and may need additional help.
That makes a lot of sense. You mentioned this diagnostic odyssey, and so many of the patients that we talk to across the rare disease spectrum or the underdiagnosed spectrum speak of these diagnostic odysseys, 10 years plus. You mentioned it as well. When people are thinking a little bit about myositis and the initial symptoms and how they're navigated towards a diagnosis, can you walk us through a little bit of that? I think that would be helpful, again, for folks coming from the lay community.
Yeah, no, that's great. And I do think this diagnostic odyssey is improving
Mhm.
for big reason because there has been better recognition of someone is weak. Let me check a CK level first. Great first triage.
Mm.
It's high. And, us neurologists and rheumatologists don't get excited about a CK of 300 or mildly elevated. But if it's over 500, you have our attention.
Sure.
Only if it's over 1,000, we become very suspicious of muscle disease.
Mm.
There are other neurogenic conditions that can cause mild CK elevations.
Mhm.
But when it's elevated, I think even just going straight to a referral to a rheumatologist or neurologist may be very helpful for a primary care physician, a family practitioner that doesn't see these patients.
Yeah.
Typically, then nowadays a myositis antibody panel is a very easy blood test to send off. Even with that initial screen, once that CK level comes back,
Hmm.
there are several labs around the country that do myositis antibody panels. You don't even have to know which antibody to look for. You just write myositis antibody panel, Quest, Mayo Clinic, WashU, Oklahoma are some of the very common labs that are used to look for these autoantibodies. If
Hmm.
positive, that can be a very sensitive first test.
Hmm.
Also use of course, muscle biopsy as a confirmatory tissue diagnosis. And when you go to these myositis meetings, many still are now even debating, do we need muscle biopsy
Oh,
or not?
really? Huh.
Or is the antibody enough?
Hmm.
Some of us think if the antibody is consistent with the clinical features, then it's not always absolutely necessary to get a tissue diagnosis.
Okay.
Same time, many clinical trials still require a tissue diagnosis,
Okay.
or if the patient hasn't had a great treatment response,
Mhm.
then it leaves you with your head scratching. And so you think, I should have gotten a tissue diagnosis initially.
Right.
No stone unturned.
Hmm.
We also use some ancillary tests. We
Okay.
like EMG, electrodiagnostic studies to
Mhm.
confirm that the proximal muscle weakness is truly a muscle disease and not a neurogenic disease. There
Okay.
are some
There's some
mimicker.
differences? Yeah.
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 And
Interesting.
then lastly, I think the last test that we like these days and more commonly used is a muscle MRI.
Mhm.
Because a muscle MRI, there's two sequences. STIR will tell us if there's ongoing inflammation,
Mhm.
which muscles are affected, which can increase your yield for muscle biopsy.
Mhm.
If you do a muscle MRI of the thigh and you see increased edema in the vastus lateralis, that's your muscle to biopsy.
Hmm. Perfect.
Uh, and if you see a lot of fatty T2 signal, then it shows that there is a lot of end stage muscle here, and maybe you want to avoid that muscle and pick a muscle that has more stir signal.
Right. You don't wanna biopsy something that is not gonna get you any result, right? Yeah.
Exactly.
Yeah.
Yeah.
That makes a
So
lot.
to summarize, my four favorite tests are CK, myositis antibody, EMG, and muscle MRI to really complete the picture.
Yeah, like a full panel, if you will, right? So and you mentioned a moment ago about, qualifying for clinical trials, and certain tests needing to be done to do that. As you think about clinical research and what's going on right now, because 'cause I'd like to, maybe move the conversation a little bit more towards what the treatment options are. You and I talked a little bit before about IVIG and, this kind of notion of I think I've heard it called medication or medicated remission, is maybe the term I've heard. Maybe you can correct me on that. But I'm interested in your perspective on what's happening in the clinical research space now, and what are some of the either trials or therapeutic advances for myositis that are getting you sort of, really, really excited.
Yeah. And that's the super end question for these patients, right? And so, one is making sure the diagnosis is correct. And just to back up a little bit,
Sure.
this is why we talk so much about the autoimmune muscle diseases,
Mm,
the patients with IBM.
mhm.
And it's so important. About 30 to 40% of IBM patients are initially misdiagnosed as polymyositis, which is sort of in that autoimmune category.
Okay.
And these patients, it is super important to get the diagnosis correct
Mhm.
because these are the patients that unfortunately will be placed on several autoimmune medications.
Oh.
And then they realize, wait a second, they're not getting better. What's
What's
happening?
happening? Yeah, what's the problem?
Yeah.
Yeah. Yeah.
And so for these patients, the IBM patients, it is really important to get that tissue diagnosis confirmation
Mhm.
and check the autoantibody, which is not in the myositis antibody panel.
Mm.
You actually have to think about it and order it separately.
Wow. So
So, that autoantibody is called NT5C1A,
mhm.
and it's detected only in about 50 to 60% of patients.
Mm.
So, it's got high specificity, but not high sensitivity.
Sensitivity. Okay. Yep.
Um, and I think that I just wanted to pause and talk about that for a second
Please.
because I've met so many patients, hundreds now, that have been on some autoimmune medication when their neurologist, rheumatologist, care, care provider realized, wait a second, you're not responding,
Mm.
is something else.
Something's
So
else.
so checking that right away could avoid unnecessary and unwarranted immunotherapy for those patients.
Mm.
Um, but let's take the autoimmune patients, which
Sure.
are dermatomyositis, antisynthetase, necrotizing myopathy. For the most part, as a category, they all respond to immunotherapy and
Okay.
some form of immunotherapy. So we can even bunch them together and say, steroids are typically first line immunotherapy. These days, there are so many sophisticated medications.
Right.
uh, and yes, my goal is to always get someone into pharmacologic
Okay.
remission.
Okay.
And then hopefully remission where we can even wean patients off. And I have successfully gotten patients even from pharmacologic remission to off medications. But many medications, immunosuppressants are out there, steroids. We sort of categorize them as first line therapy, along with IVIG for patients that have severe weakness.
Okay.
We start with IVIG right away because we want to sort of blast them
Mhm.
with therapy, treat aggressively up front
Mhm.
is the idea.
Mm.
And then the steroid sparing agents become very important because you don't want to leave someone on steroids.
For a
Steroids
long time. Yeah.
are a great drug,
Yeah.
but I call it my ugly drug
Yeah.
because of all the side effects.
We certainly talk to patients who have, to your point, been on steroids for a year and the complications that are associated with that. It is not a long-term solution, right? You're the last person I need to tell that to.
Yes,
Uh,
and like patients will hate you for
yeah.
that. And understandably so. And I think everyone now has recognized it used to be, people would be on 40, 60, 100 milligrams of prednisone
Mm.
for months to try to get them better. We now realize that even 20 milligrams of prednisone is a lot.
Yeah. Yeah.
We really work hard to try to get them down, which is why, some of the things I do is do IVIG, start them on a steroid sparing agent pretty early because I know that a steroid sparing agent may take 6 to 12 months
Mm.
to be effective. But the other thing that I think is really important is telling yourself that in 6 months, if I don't see not subjective, but objective improvement. If their muscle strength is, unable to get anti-gravity,
Sure.
they get anti-gravity within 6 months.
Mhm.
If they're not, is this one going back to the diagnosis, is this a correct diagnosis? Or do I now need to look at better, more refractory type medications like rituximab?
Sure.
That's become a favorite for patients with interstitial lung disease,
Sure. Yep.
for some of the necrotizing myopathy patients.
Mm.
The harder hit them harder to see if that could work. But not waiting 2, 3 years, but waiting 6 months
Sure.
and saying, "Should I switch?"
Sure. You, for a second, had my mind sort of racing from the sort of standardized approach of the diagnosis sort of panel to this, because you made a couple comments about, oh, when you're ordering this, you also need to remember to do this or think about this. And I know you've done a lot of work with myositis.org, the Myositis Association. Um, is there a standard, I guess, for lack of a better word, Dr. Goyal, is there a standard diagnostic approach that is sort of being now, formed and advocated for at either a national foundation level like TMA or other sort of standardized bodies? I just, again, coming from the public health perspective, it's like, well, the more standardized approaches we have that everyone is following is the better. It just made me think about it as you were kind of talking about, oh, you have to think about this and you have to think about this and you have to think about this. Are there guidelines? I guess is what my long question is, are there guidelines?
Yeah, no, that's a great question. I do think there are now several organizations, including the Myositis Association, which um, does produce some content on their website.
Mhm.
Have providers sort of take a look and say, is there some good resources out there for me? I can't say that there is one specific guideline.
Sure.
Um, but I do think that there have been several efforts made. I meet with myositis experts nationally and internationally, and I think there's several publications out there.
Mhm.
Um, I know I've written on continuum in neurology
Okay.
and published even just on how to approach autoimmune
Mhm.
muscle disease. Um, and how to approach inclusion body myositis.
Mhm.
So there are definitely publications,
That are out
several
there. Yep.
myositis organizations, and and going back to treatment, even when they don't respond to sort of first line, second line, third line agents.
Mm,
This is where we then look at clinical trials.
mm.
Clinical trials have become super important because, one, there's been a robust interest in clinical trials. So, a lot of pharmaceutical companies are really recognizing that we need to do better.
Yeah.
And, we may have agents where we don't have to put patients on steroids. That's the dream in the future,
Right.
and get them in remission even faster and sooner
Mm.
so that they're not living with myositis.
Think it's really interesting because, again, one of the topics we often broach on this conversation of rare diseases or underdiagnosed diseases is that the pharmaceutical support isn't there, right? So it's encouraging to hear that in this case there is some recognition as part of.
Yes, and
Yeah,
in
yeah,
fact, it's almost become a nice problem for us in the past few years
yeah.
because we have several parallel trials going on, and there's been a lot of interest.
Mm.
And then, the other very important avenue for patients is the multidisciplinary
Sure,
support
sure.
that patients need.
Speaking of patients, I'd like to, kind of get your thoughts a little bit. We've talked a little bit now about the provider aspect of this, and you are on the medical advisory board at TMA. I think you're the chairperson of that advisory board. And I know that for patients, any journey like this, right, is really challenging for patients as they try to find those pieces of the community out there, whether it's TMA or anything associated with how do I find more people like me if I'm early in my diagnosis? What are some of the conversations I think that you have with patients in that regard, doctor?
Yeah, and I think that, the patient journey becomes super important because, you know, it's important to recognize that these patients don't, even with autoimmune myositis, they don't turn around tomorrow.
Right.
Some patients require years, if not 20, 30 years of immunotherapy, and you meet these patients with long-standing myositis, complications either from medications
Mm,
or from the disease. And so at UC Irvine and many centers nationally and internationally, we try to approach myositis with multidisciplinary care.
mhm.
So patients have that support not only from the neurologist, rheumatologist, but we recognize that they need a physical therapist. They need to do exercise.
Sure.
There was a misnomer that if you're super weak, you shouldn't exercise the muscles or you could harm them.
Right.
But that's not the case anymore. We know that stretching, range of motion, depending on your strength level, and a PT that specializes in this can give the correct guidance.
Mhm.
Swallowing becomes an issue for many patients, so we have a speech therapist that recognizes and helps them show how to modify their diet
Mm.
so they're not choking or aspirating.
Sure.
Um, Unfortunately, in some patients, the diaphragm
Mhm.
gets weak, and so we have a respiratory therapist in our clinic, especially if there's interstitial lung disease.
Mhm.
We can monitor their pulmonary function tests with making sure that the diaphragm is supported. And if we need to, we start them on BiPAP or non-invasive
Mhm.
ventilation.
Mhm.
A social worker,
Sure.
the caregiving support.
Sure.
Um, the caregiver needs support. The patient needs support. It's a lot for families sometimes. Some patients become wheelchair dependent.
Mm.
To talk about disability. We need to talk about how we can get more support for the family and the patient.
Sure.
So all of these resources are tremendously valuable.
I really okay.
Oh, sorry. No, go ahead.
I was just again, from the public health perspective, I really appreciate how you mentioned the social worker and thinking about, um, the social determinants of health that may also play into these conversations because I'm going to assume that where you are from a geographic standpoint, you are seeing, some disparities in equity, as it relates to your patients. You are seeing instances where it's really important for folks that have limited access to certain specialists or, where you can kind of work from a continued involvement in some of that, moving the rare disease community forward, I guess, but in a way that is more systematic, right?
Yes,
Yeah.
and, unfortunately, I feel so fortunate to have built this team where when patients come from different backgrounds of all sorts, we just get on it and we as a team try to provide care. But
Yeah.
I also recognize that many patients nationally and internationally don't have access to these resources
Right.
is where my involvement and there are many patient organizations.
Mm.
I'm most familiar with TMA or the
Sure.
Myositis Association because I've been a medical advisor for them
Sure.
since 2016 for 10 years. It's purely voluntary. I do it because
Yeah, it's important to you, right? Yeah.
it's become a great organization for support for the patients.
Mhm.
One of these conferences where I go to annually, and I get to meet somewhere between 400 to 600,
Oh my goodness.
sometimes even 800 patients over the years. I've seen, patients join via Zoom. And what's really cool about it is medical advisors come from all over the world.
Mhm.
They give lectures from the basics, like guidelines on how to approach this, to how to treat this, to how to deal with some of the different systems involved. And it's purely for the patients.
Mm.
So patients have opportunities during these sessions to ask questions, and we have several sessions over a 3-day period, and it's become a really great resource for patients. The other nice thing is many of these lectures are recorded
Sure.
and on YouTube, so they can
See
check
the
and see them, and they can join nowadays via remotely for some of these lectures. So it's just been a great opportunity. And for me, it's been great to learn from the patients.
Yeah.
I learn from these patients. I hear their voices. I hear what we need to do better.
How are you, planning on heading to Dallas this September?
Oh, for sure.
Yeah.
The meeting is in Dallas, like
Yeah.
you mentioned, and they actually have some fun events planned
Oh,
too.
great. That's
Um,
awesome.
And so it becomes, a really fun networking meeting where, I sit on during lunch, I sit with the patients and I get to hear how patients are even giving them each other advice.
Nice, sure, yeah.
It's a nice meeting.
One of the care partners that we spoke to, you probably know who I'm gonna refer to in a moment. He's a little bit of a celebrity in the care partner community. This is, Mr. McGrath. I think he told me he's attended all but one MyoCon, with his wife, and they're working through her myositis diagnosis, but I don't know if you're familiar with him or not.
Yeah, no, I mean, what's really cool is, like you said, some of these patients have been attending for years
Right.
and become the celebrities, and they, are so well known and popular and become the voices. What's also neat is TMA also has local support groups.
Oh,
So,
that's great, yeah.
like, I know here in California, there's a support group in San Diego.
Mm,
And so many of my patients, the conference moves around the nation
mm,
year. But if patients can't attend, if they're, have commitments or they're wheelchair dependent, they can also join their local support group
mm,
and get a lot of resources and information. And it's all listed on the TMA website.
it's outstanding. One of the other things that has really stood out to me during the course of our conversation is your role as clinician to educator to advocate. How do you kind of manage all of that, Namita, from a just a person perspective?
I think it's just because when there's a passion,
Uh-huh.
it all seems really fun. I do a lot of my research nights and weekends
Sure.
because and I get inspired from the patients.
Right.
As I'm sure you've met over in public health, you hear a patient's story and you realize that could be a clue to
Mm.
something treatment-wise. So,
Yeah.
I do work with a lot of pharmaceutical companies because I hear from the patients,
Sure.
why should I be on steroids for 20 years?
Right.
Is that acceptable
Right.
at this day and age when we're curing cancer? So, we should be doing better, and I love that, and I
Yeah.
love that challenge, and the flip side is I get also encouraged knowing that I've gotten people in pharmacologic remission,
Sure.
and I've gotten people off medications. I have patients writing to me that I was in a wheelchair and you gave me my life back. I've
Wow.
gotten my job back. I put my kids through college,
Amazing.
and it's so inspiring. The
Sure.
pa
How can you say no to something like that, right?
Yeah,
I mean, especially when again, I've talked to a couple of patients, and knowing that they've gone from being able to not manage their ADLs to now being able, and you think of that as a small thing, but it's really not, right? I mean, it's such a huge difference in someone's life to go from fully dependent on their ADLs to being back to independent, right?
yes. I
Yeah.
mean, I'm thinking of a 40-year-old that, had to, move out of his house
Mm.
because he was living in an apartment where there were only stairs and, he's now gotten his life back,
Yeah.
and
Amazing.
it's so
Amazing.
inspiring. And
Yeah.
then the other bucket, which we should talk about,
Mm,
is the inclusion body myositis patients
mm,
where we haven't yet gotten a treatment. There have been several autoimmune therapies over the years,
mhm,
many clinical trials that I too have been involved with,
mm.
haven't worked for these patients.
Sure.
It's actually the most common acquired muscle disease
Mm,
over the age of 45
mm,
can affect any one of us.
mm,
And so, I do work with pharmaceutical companies and researchers in the community to find better therapies for these patients.
mm.
Like, I don't accept that we don't have something for
Right,
them.
for those folks.
Yeah.
As you think about, your hopes for the future as it pertains to myositis, but then also I'd love your thoughts about the larger rare disease community moving forward too. Um, Dr. Goyal, what are some of the things that I think, are making you most optimistic or continue to make you optimistic? Again, thinking about it from your role in advocacy, plus medical education, plus as a clinician yourself. I guess what are some of things that are making you most hopeful for the rare disease community?
Yeah, I think back to when I started, which, surprisingly feels like yesterday, but it was 20 years ago. Um, like, realize how much better we are doing in that diagnostic odyssey,
Yeah,
and having I love when I see a patient and, I'm seeing them for a second opinion, but everything's already done.
right.
The antibodies are checked, the muscle biopsy has been performed, and, that didn't happen, and
Yeah,
so
I can see why that would excite you. Yeah, yeah.
is getting better. The diagnostic time and delay, I think it is getting shorter, and, the amount of pharmaceutical interest there has been,
Mm,
and yes, even these patients do get better with steroids, but shouldn't we be doing better?
yeah.
That's happening now, and the scientific advancements, even in the last 5 years is just faster and faster,
Mm,
um, and the support is there? So I wanna see a future in 5 to 10 years where we don't see
right.
patients affected for years with
Sure.
myositis.
Sure. Wow, wouldn't that be amazing? Wouldn't that be amazing? And I guess the last sort of reflection I really appreciate your perspective on is if I knew someone or myself was to wake up tomorrow and understand that, oh, I'm newly diagnosed with this, do you have a message for those people who are newly diagnosed and probably feeling particularly overwhelmed in that moment?
Yeah, and that's we see so many of those people,
Mm.
and I love telling people that, um, if you feel like you're not getting better,
Mhm.
ask for that second or third opinion. The nice thing about the medical advisors, even on TMA,
Mhm.
is that um, they are welcome to, you emailing them, asking the question. I
Mhm.
get many emails nationally, internationally about,
Oh,
"I have
wow.
a patient, can you give some advice?" All the medical advisors on the TMA website
Mm.
are very approachable. So for the patient, ask the questions, feel empowered, you have that right,
Mhm.
to make sure that you are on the right diagnostic journey and treatment journey,
Mhm.
is many patients respond well
Sure.
with direct immunotherapy,
Yeah.
and so we do wanna see you better.
Absolutely. We certainly want to see you better. That's the goal, right? That's the end game for all of this. Folks, we have been speaking with Dr. Namita Goyal from UCI Health, also part of TMA, the Myositis Association. I'm going to encourage everyone listening to please go to myositis.org, connect with Myositis, look at their support the association if you can. And once again, Dr. Goyal, thank you so much for your time today.
Thank you, Richard, for taking the time. I've loved this talk we've had. Thank
Great.
you.